Good afternoon. I think we're going to get started. Welcome to the annual Clarence Guenter lecture. This lecture is an annual event to honor Clarence Guenter, who has done a lot of work and has a lot of expertise in global health. And this lecture is sponsored by the Global Health Office here at the University of Calgary. The Associate Dean of Global Health is not able to be here today, but was able to videotape a welcome and to introduce the Clarence Guenter lecture. I also would like to extend a welcome to all of our international guests who are also here from many different countries across the globe as part of the first lecture for the Bethune Roundtable as well. So welcome to you all. And we'll begin.
My name's Jennifer Hatfield, and I have the great pleasure of being the Associate Dean for Strategic Partnerships and Community Engagement here at the Cummings School of Medicine. I'm very happy to welcome everyone here. And I'm speaking to you, and this message is being recorded from our research field school in Tanzania. We are connecting with community here as we try and connect with communities within our own city of Calgary and our province of Alberta. And I have the tremendous honor of welcoming you to the Clarence Guenter Annual Global Health Lecture. Clarence Guenter is a mentor and has been a support to people around the world who are trying to improve the health education systems within their countries. Clarence is an immensely modest man, and so I will not go on and on about his contributions. But I do want to say one very important thing, and that is that Clarence has taught us about partnership, the meaning of partnership, and the quality of the partnerships that we need to have that are ethical and equitable. And so I need to make that point because, Clarence, this has been an enormous gift that you've given to all of us. The Clarence Guenter Lecture brings to Calgary important leaders from around the world to talk to us about the importance of global health, and also about the need for all of us to be thinking about equity in health and how we can work towards that objective. Regardless of whether we're working in Africa or in Canada or in many of the countries where I know you all come from and where you all make an enormous contribution, we come together today at the Clarence Guenter Lecture to learn more about how we can do this well. Clarence is a mentor to me. He's been a mentor to many of us here at the University of Calgary. And so this lecture is an important part of us acknowledging his legacy. So it just remains for me to welcome you all, to say I'm sorry I'm not there in person, but to know that I can turn this over to my friend and colleague, Dr. Gwen Halar, to introduce our honored speaker. And I know this is going to be a fantastic conference for you. The theme of community engagement is deeply meaning to all of us. So thank you so much for being here, and thank you for attending the Clarence Guenter Annual Global Health Lecture.
Can you hear me? Oh, great. Thank you. So my name is John Kortbeek. I'm the Department Head of Surgery, and I, too, would like to welcome all of you to this fantastic conference. I'd like to thank Gwen and the organizing committee for all of the hard work that they've put into the next several days, and I'm really looking forward to it, and I hope that you enjoy it as well. I'm also looking forward to meeting many of you and making some new friends and some new connections. It does give me great pleasure to have the honor of introducing our guest speaker today, and I was speaking to Dr. Roger Strasser for a few moments before he came, and he's a busy man, and he's flown in, and he'll be flying out at midnight tonight, so I'd like to really thank him for coming. He has international stature and renown as a leader and advocate for rural care and social accountability, so I'd like to share a few of his accomplishments with you. So Dr. Strasser was appointed as the founding dean to lead the creation of the first new medical school in Canada for over 30 years, the Northern Ontario School of Medicine, in 2002. This school is unique in Canada. It's a joint initiative of Lakehead University in Thunder Bay and Laurentian University in Sudbury, and these universities are 1,000 kilometers apart. There is no other relationship or establishment like that in the country. Prior to his appointment with the Northern Ontario School of Medicine, Dr. Strasser was Professor of Rural Health for Monash University and head of the Monash University School of Rural Health in Australia. Between 1992 and 2004, he also had an international role as chair of the Working Party on Rural Practice of WONCA, the World Organization of Family Doctors. In 2002, he was awarded the Honorary Fellowship of the Royal College of General Practitioners in recognition of his world leadership in the field of rural health. And in March 2003, he went on to receive the Louis Ariotti Award for Excellence in Innovation in Rural and Remote Health in Australia. He also received the prestigious award Fellow of WONCA, which was presented in 2004 in recognition of his outstanding service to WONCA and family medicine around the world. In 2005, Australia's Monash University held a special ceremony to rename its auditorium in Dr. Strasser's honor. The Roger Strasser Auditorium at the Latrobe Regional Hospital pays tribute to his contribution to the development of rural medicine and education programs in Australia and around the world. In 2006, he was named the inaugural winner of the Small, Rural, and Northern Award of Excellence by the Ontario Hospital Association in Canada, and also received the Australian College of Rural and Remote Medicine Life Fellowship Award for Outstanding and Meritorious Service to Rural and Remote Medicine in Australia. That's a double hitter if I ever heard one, north and south, both ends of the world at the same time. On Australia Day 2011, Dr. Strasser was appointed a member in the General Division Order of Australia. The Order of Australia recognizes the achievements and service of Australian citizens with nominations submitted directly from the community. The honor bestowed on Dr. Strasser specifically for service to medicine through improving the health care of people living in rural and remote communities in the developed and developing nations as an educator, a researcher, and a practitioner. In 2011, Monash University bestowed on Dr. Strasser the award of the Monash University Fellowship, an honor awarded by the Council of the University in recognition of the achievements that alumni have made and continue to make throughout their professional distinction and outstanding service. And finally, the Prince Mayudal Award Conference on Transformative Learning for Health Equity was awarded in January of 2014. He received a special award for outstanding health professional educators, which recognized educational innovation leading to the production of quality health professionals for rural and remote areas, and also recognizing his visionary leadership that has changed the paradigms of learning. Please join me in welcoming Dr. Roger Strasser.
Can you hear me with this? Yep, seems to work. Well, thank you very much for that rather overlong introduction, but if you're still awake, I'm going to now say a few things myself. I really want to say thank you very much for asking me to come. It means it's a great honor and an enormous privilege, really, to be here to deliver the fourth Clarence Guenter lecture. I met Clarence only for the first time a few minutes ago, but I'm well aware of him as a trailblazer in global health. The other two previous lecturers I know very well as colleagues and friends. Fortunato Cristobal, known as Chris, from Zamboanga in the Philippines, and Arjun Kaki from the Patan Academy of Health Sciences in Nepal. I mean, they are truly charismatic leaders of innovative health professional education in low resource settings. And so it's rather daunting for me to follow such a series of lecturers and to do a presentation today. Nevertheless, I'll give it a go. And what I'm going to do is talk about social accountability, about global health, and explore the concepts really telling you the story of the Northern Ontario School of Medicine and the Training for Health Equity Network. So I'm going to actually tell you a little bit more about myself, even though you've heard a lot. That gives you a sense of who I am and where I'm coming from, to then talk about social accountability, talk about global health as sort of an introduction really to telling you about Northern Ontario School of Medicine, the first, not only the newest medical school in Canada, the first medical school in Canada established with an explicit social accountability mandate, and then the Training for Health Equity Network, which is a global collaborative where the focus is on social accountability and achieving health equity. I don't think there's anything there in that disclosure that suggests I have any conflict of interest. I do have an absolute passion for global health and for social accountability, as I guess you'll hear. Okay, so as you heard, I come originally from Australia. I grew up in Australia, went to medical school, trained to become a rural physician, and as is common, at least in those days it was for young doctors in Australia, then I started travelling. I went to the UK for a couple of years, and I actually came here to Canada. This was in the mid-1980s, and I undertook my academic training. And by the way, these maps are to scale, so it gives you a sense of how big Australia is, knowing already how big Canada is. And anyway, so I came to Canada, did my academic training for a couple of years at the University of Western Ontario in London, and then I went back to Australia, never expecting to return to Canada other than as a visitor. I quickly was settled into rural practice and became involved with Monash University, which actually is the school that I graduated from, and drawn into the academic focus around rural practice and rural health, and was involved in establishing the Monash University School of Rural Health, which by the time I left in 2002 had 4 major sites across quite a large rural area and a network of teaching and research sites. We provided clinical education for students in medicine, nursing, pharmacy, a range of health disciplines, and also undertook research. So the opportunity to come back to Canada and be involved in establishing a new medical school that was multi-site and rural-based just seemed like the chance of a lifetime. And so here I am back in Canada now 13 years later, and I'm going to tell you about Northern Ontario School of Medicine. As you've heard, there's also a sort of international dimension to the perspective that I bring to this presentation, and in particular my role as having been the first chair of the Working Party on Rural Practice of WONCO, the World Organization of Family Doctors. And this is, we have a colleague here from Calabar. I'm just trying to, there he is. Yes, so this photograph was taken, what's the name of the place again? Okoyo. So we held the Rural Health World Conference of WONCO in Calabar in Nigeria in 2008. And part of the conference we went to Okoyo for a day, and a group of us became honorary chiefs. So if you haven't already worked out, that's me. And Ian Cooper from South Africa was the chair of the Working Party at the time. So a colleague from Australia and 2 of the Nigerian colleagues. And so I bring a breadth of perspective, I guess, to say a bit more about the Working Party on Rural Practice. Really, I think this Working Party has provided a global leadership for a focus on rural health around the world through policies, through conferences, through statements, and through engaging with the World Health Organization. So members of the Working Party from developing countries said, well, it's all very well to have these policies, but unless it's endorsed by the World Health Organization, the governments don't take any notice. And so that's when we started engaging with the World Health Organization. And it was really through that process that I came to know Dr. Charles Boland, who at the time in the 1990s was with the World Health Organization. And he really was a leader. His focus was on human resources for health, but in a number of initiatives that really still have ramifications around the world in global health, and in particularly in social accountability. So he with the World Health Organization, took the lead in developing this definition of social accountability. You can see it's about medical schools having an obligation to direct their education, research, and service activities to address the priority health concerns of the community, region, or nation that they have a mandate to serve. So that's, when we say social accountability for medical or health professional education, this is what we're talking about. And it's very interesting, over the years, including, as I'll tell you about THEnet, the Training for Health Equity Network, there have been attempts to refine or adapt or develop further the definition of social accountability, but we keep coming back to this as a pretty solid definition. It talks about the priority health concerns, and again, Charles Bolin initiated the TUFH, Towards Unity for Health, and articulated that identifying the priority concerns really is about the 5 partners in the communities, I guess whichever screen you're looking at. So communities and health managers and policymakers and health professionals and academic institutions, all 5 partners. For a while they described this as the Pentagon. Then there was this thought, well, that means something else, so it's now a pentagram, okay? But you'll see that right in the center, it's all about responding to the people's needs, okay? That's social accountability. And Charles Bolin, although retired from the World Health Organization now for over 10 years, is still very much a global leader, and actually with Bob Willard from Canada here, University of British Columbia, is leading the global consensus for socially accountable medical schools. And I'm going to say a bit more about that in a moment, but there's a considerable momentum really around the world now towards social accountability in medical and health professional education. So let's talk about global health. A few years ago now, I was asked by the residents, I think it was first the family medicine residents at Northern Ontario School of Medicine, to do a presentation to them about global health. And I have to say, I felt quite uncomfortable about that at the time, really for 2 reasons. First was that although I'd been involved internationally in various countries, as I've described, I really didn't have a sense of that meant I knew anything about global health. And it was like this idea had just come out of nowhere, and I hadn't really been, I'd been kind of busy starting a medical school in Northern Ontario. But I was also concerned about sometimes the sort of perceptions about the way that this happens. And so then I looked at the literature and realized that actually I was right. Global health as a term actually is a very new term. So back in the 60s and 70s, there was community health or public or population health, and then with the Declaration of Alma Ata, primary health care, and then international health in the 90s, Towards Unity for Health, I've already mentioned. Towards Unity for Health is really about the integration of population health and individual health care. And it's really only just within less than 10 years ago that the term global health took shape. And it makes sense that it's just less than 10 years ago, because although the term global village has been around for a long time, it's really in the last decade or so, that let's say last 15 years, 21st century, that the world really has become a global village, that there is instant communication, transportation, information transfer, and a growing awareness really of health disparities between different countries and within countries in different parts of countries. And so that then provides a focus really for considering health on a global as a global issue. And so the definition was coined in 2009 as focus of study, research, and practice, where the priority is about improving health and achieving health equity for all of the people of the world. And I think that's a very important concept to keep in mind as we look at the experiences in different parts of the world. The other point of concern I had about addressing the residents about global health was this imagery, the idea that that global health was about rich white kids going to and doing good works for the deserving poor in the third world. And that imagery still concerns me, and I have a sense that it's still around in some places. But I'm able to embrace the concept of global health by the definition that I presented, and with a clear understanding that it's about helping people to help themselves, to improve their health. And it is about the whole world, which includes Northern Ontario, which includes all of Canada. It is the whole world, not just certain sort of selected parts of the world, so to speak, and on an understanding that it's not promoting or encouraging paternalism or medical education, tourism, or worse still, voyeurism. So that's my introduction, talking about social accountability and about global health. Let's now talk about Northern Ontario. So those of you who are not from Canada, this is Canada, okay? And we're currently here. This is Alberta here, the province of Alberta, and we're somewhere down here. I'm not that good on precisely pointing to where Calgary is. But I can point out that this is Northern Ontario, so there are Great Lakes here. That's Hudson Bay and James Bay. So Northern Ontario is actually a vast territory between the Great Lakes and Hudson Bay, James Bay. It's actually Germany and France put together, over 800,000 square kilometres with less than 800,000 people. So vast territory, relatively small population, with a boom-bust resource economy, and in general the health status of the people in Northern Ontario is worse than the rest of the province and the rest of Canada. Now these two red dots, that's Thunder Bay and that's Sudbury, and as you've heard, they're 1,000 kilometres apart. Thunder Bay is about 120,000 population. Sudbury is about 150, 160,000 population. So they're the two large population centres in Northern Ontario. There are three others that have a population of 50,000 or more, and all the rest are more or less 10,000 or less. So lots of small communities, large distances between them. That's Northern Ontario. And it's in that context that back in 2000, 2001, there was a widespread community movement which said if we're ever going to turn around the shortage of doctors and other health professionals, if we're ever going to improve the health of the people of Northern Ontario, we need our own Northern Ontario School of Medicine. And I don't know what was happening back then in Ontario, because in my experience, it's not often that government actually kind of responds positively to this kind of advocacy, but they actually said yes. And so in 2002, as you've heard, I came over from Australia and joined a group of others in the process of establishing Northern Ontario School of Medicine. The school opened officially in 2005, so if you're doing the math, it's 2015. We're celebrating our 10th anniversary this year, so the school's been going 10 years. The school serves as the Faculty of Medicine of Lakehead University in Thunder Bay and as the Faculty of Medicine of Laurentian University in Sudbury. And we're a School of Medicine for the whole of Northern Ontario with a social accountability mandate. Actually written into the founding documents of the school is that commitment to be responsive to the needs of the people and the communities of Northern Ontario with a focus on improving the health of the people of Northern Ontario. There's also a commitment to innovation. As we said about developing the education and training activities of the school, we drew on research evidence from around the world which shows that the three factors most strongly associated with going into rural practice after education and training are first, a rural upbringing. That's having grown up in a rural area, okay? The second factor associated with going into rural practice after education and training is positive clinical experiences in the rural setting as part of the undergraduate education, so the MD program for medicine. The third factor associated with going into rural practice is targeted training for the graduates. After graduation, targeted training prepares the graduates to practice in the rural setting, so that's residency training. And so, based on this evidence, we have developed the education and training activities of the school with the idea in mind of the life cycle of a physician or a health professional in Northern Ontario. And you can see that we have a full range of medical education through the cycle, I suppose, MD, residency, continuing education, professional development. We're just in the process of introducing graduate studies, masters and PhD as well. We're also involved in producing other health professionals in Northern Ontario, very much an emphasis on interprofessional education, and the research that we undertake in the school is also guided by the social accountability mandate. That's addressing research questions, the answer for which makes a difference to the health of the people of Northern Ontario. Distributed community-engaged learning is the distinctive model of medical education and health research which we developed for Northern Ontario School of Medicine. Distributed means that the teaching learning activities occur at multiple locations, sometimes connected in real time, so synchronously, sometimes asynchronously. This means that we rely heavily on electronic communications to connect all of the sites of the school. And we have an extensive digital library service. And in fact, as long as they have access to the internet, our students, our residents, our other learners, our faculty members, our community members, if they have access to the internet, they have access to educational resources and information pretty much the same as if they're in the big city in the teaching hospital environment. Community engagement really is the centerpiece of our of the school, and it's the interdependent partnerships that we have with communities right across Northern Ontario. We have over 90 sites where our students and residents may undertake part of their clinical learning, and so this is a map that gives you a bit of a sense of what distributed community engaged learning looks like, and the color coding, maybe I'll point to this one, is different parts of our MD program and then our residency programs and our other health professional programs. So it shows that all of our programs are distributed community engaged learning. For those of you who don't know Northern Ontario, these communities are remote fly-in, fly-out First Nation communities, and our students in the MD program, the first year of the MD program, have 4 weeks where they're living and learning in those communities. It's an immersive experience. The students are there to learn from the communities about the history, the tradition, the culture, the social and the health issues of the Aboriginal communities. So, and then in second year, the students have 2 4-week rotations in small communities like Terrace in northwestern Ontario, and that's a clinical experience. The students are there to learn from the doctors and the members of the health team. So they're starting to learn clinically. And actually this slide is a sort of visual of our entire MD curriculum. So to give you a sense of the community, I've mentioned 106 here is the Aboriginal community experience. 108 and 110 are the integrated community experiences in second year. We actually have a half day each week in first and second year where the students go into, it's called community and interprofessional learning, and they go into a range of health and welfare services, about a third where students are the main service providers, a third where a third where physicians are main service providers, a third where other health professionals are main service providers, and a third which are more community or welfare services. So that's right from the beginning. Our students also start learning their clinical medicine right from week 1 in year 1. We have each week a half day in the clinical skills lab. Community members, volunteers come in and they're trained to standardise patients. So they're helping our students to learn the skills of interviewing and physical examination right from the beginning of the program. And then third year, this is here, so I know you have a 3-year MD program at University of Calgary, and we chose not to have a 3-year program, and I can tell you about that if you're interested. So we have a 4-year program, and like in other medical schools with a 4-year program, that third year is the year where the students make the transition from being classroom learners to clinicians. I should say that our classroom learning, I think more like yours, it's mostly in small groups. It's what we call patient-centered case-based learning, and the cases are complex, real-life scenarios set in real Northern Ontario communities. So if you, in a sense, the students are learning in context as if they're going to practice in Northern Ontario, even in the classroom. So then we get to the end of second year into third year, and in third year, the students leave Sudbury, they leave Thunder Bay, and they move to one of 15 large rural or small urban communities, and they live in that community for the whole year. It's an 8-month academic year, and they're based in family practice. This is a longitudinal integrated clerkship. All of our students undertake that. We're the first medical school in the world where all of the students do a longitudinal integrated clerkship. The students are based in family practice, and they see patients. And you could say the curriculum walks through the door. Okay? The first patient might be a child, that's pediatrics. The next patient might be pregnant, that's obstetrics. The next patient might have a surgical problem. The learning objectives in the third year in the 6 core clinical disciplines are just the same as in the other medical schools, but the learning environment is very different. Our students are learning their core clinical medicine from the community family practice perspective. And it's only actually in 4th year where they have block rotations in the tertiary care centres, the regional hospitals in Sudbury and in Thunder Bay. So that's a quick snapshot of our 4-year MD program. And this slide is another quick snapshot of the various curriculum innovations that we have. So I've mentioned case-based learning, and learning in context was very much a theme. Longitudinal learning, we have 5 themes that run through the 4 years of the program. We have the longitudinal integrated clerkship. We call it comprehensive community clerkship. Distributed learning I've mentioned, but I'm going to really home in now on community-engaged education and explore a little more about community engagement, which really is the centrepiece of Northern Ontario School of Medicine. So this is about, as I said, the interdependent partnership between the school and the communities. It's about the communities being actively involved in development and delivery of our programs, the communities hosting our students when they're when they're learning in the communities. And of course, it's of great importance to the communities because every student is a potential future recruit as a physician in that community. And the communities are in all other sorts of ways are involved in our education and our research activities in a way that really is community capacity building. We have 3 populations of special interest in Northern Ontario, so apart from the sort of urban setting, so to speak, and the first is the Aboriginal communities. The first public event of Northern Ontario School of Medicine was a curriculum workshop, which we held in Sault Ste. Marie. Sault Ste. Marie is sort of, not quite halfway, but it's between Sudbury and Thunder Bay. And we chose Sault Ste. Marie deliberately, so it wasn't Sudbury, it wasn't Thunder Bay, to confirm that we were going to be a School of Medicine for the whole of Northern Ontario. And we've now moved to actually describe the entire geography of Northern Ontario as the campus of the Northern Ontario School of Medicine. So that curriculum workshop, which was held in January of 2003, we invited anybody and everybody to Sault Ste. Marie who had an interest and wanted to help develop the Made in Northern Ontario dimensions of the school, and particularly our MD curriculum. We thought if we had 200 coming, we'd be doing pretty well. We had over 500 expressions of interest. We could only fit 300 into the venue, so we had about just over 300, and about 100 of them were physicians, 80 academics from the universities, 50 Aboriginal people, 50 Francophones, people from local government, from small communities, large communities, the whole of Northern Ontario really represented. And at that workshop was really the kickoff, was getting started for the school, and it became clear to me at that workshop that if we were really going to understand the needs of the Aboriginal people and to develop a medical school which was their medical school, we need to have our own separate workshop. And so you probably can't read this, but in June of 2003, this is a First Nation just near Kenora, we had the first Aboriginal workshop, which we called the Follow Your Dreams workshop. And we spent 3 days in this First Nation, and we were in large circles and small circles. Many of the speakers were Aboriginal people who were physicians at the time or medical students at the time, talking about their experience of getting into medical school, going through medical school, getting out of medical school. I have to say that generally what they reported wasn't a very pleasant experience. And so in the small circles there were lots of discussion, and that led to a series of recommendations which are in this report from the workshop, and really provided the direction for the school in developing the Aboriginal dimensions for the school. The headline, I guess, of the recommendations was an Aboriginal-friendly medical school. A lot of the other recommendations, of course, we implemented, such as having an early immersive experience in Aboriginal communities, and also establishing an Aboriginal reference group, which is an advisory committee to me as the dean to kind of make sure that I keep focused on those recommendations and the expectations of the Aboriginal people. And then roughly every 3 years, we hold another Aboriginal workshop. We now call them Aboriginal Community Partnership Gatherings. And so the next one in the series was in 2006. This was the Keeping the Vision workshop. In 2008, we held one that was about research. That's when we called that the Partnership Opportunities in Research Gathering. And of course, it's the ultimate culture clash, really, the worldview of Aboriginal people, the worldview academic researchers. So you can imagine we had some very interesting discussions. Again, it was something over 100 Aboriginal people and about 30 academics, most from Northern Ontario, but some from the south, from Toronto as well. The Living Division was the next one, and the Walking Division is the most recent. That was just this past August, and we were in the Chapleau Cree First Nation for that workshop. Francophones, so our second population of special interest, are people for whom French is the home language, and we have a similar sort of form. The priorities and the interests are different, but the form is similar. A Francophone reference group and what we call symposia. And the next one is coming up just in September this year. In September, we have big celebrations in Ontario, 400 years of Francophones in Ontario, 40 years of the Franco-Ontarian flag, which happened to have been invented by an academic at Laurentian University, and 10 years of Northern Ontario School of Medicine. So we're having a Francophone symposium in September this year. And the third population of special interest are the remote and rural communities. And so in each of the 15 communities where the students are for the third year, we have what we call a local NOSM group. This is the mechanism by which the school is a part of the community and the community is a part of the school. It's kind of like a steering committee for the school in the community, and as you can see, the membership are civic leaders. Sometimes the mayor is a member of the local NOSM group. Other community leaders, including if from education, if there's a post-secondary education institution, they're represented, as well as physicians, other health professionals who are faculty members of the school. And so that's a key element really in making the community engagement real for those communities in Northern Ontario. And the faculty. Our concept of a faculty member for Northern Ontario School of Medicine is that you're a faculty member without any qualification. So a physician or another health professional in a small community like Terrace is a faculty member of the school just as much as a PhD that we employ as a faculty member at the school, or a specialist or subspecialist in the regional hospital. They're all faculty members, and we work very hard to support and encourage all of them to develop the interests and the skills in terms of an academic career pathway, so research and teaching, education, other scholarly activities, and we put quite a bit of effort into rewarding and recognising them. This is just a page out of a recent Northern Passages newsletter, which highlights achievements and gives recognition to faculty members of the school. So community engagement is much easier said than done. Let me just remind you that people in communities generally see universities as ivory towers. And if they have an experience of interaction with the university, it's the university coming to them and telling them what the university wants them to do for the university. So, us coming along as a School of Medicine, even after the community movement, everything I described, it wasn't just taken as given that we were serious, that we really were wanting to have an equal partnership and for the communities to contribute. So it was very much important to be there in the communities, to connect, to reconnect, to listen, and to see the vast geography, the social, cultural, linguistic, geographic, cultural diversity of Northern Ontario as an opportunity, as something that's really special and that we want to make the most of. And it's very important to formalise these relationships. So we have collaboration agreements, hundreds of collaboration agreements with hospitals and health services, obviously, but also with a whole range of other organisations that we partner with. In fact, the rapid development of Northern Ontario School of Medicine has only been as a result of partnerships and collaborations, because it's been all of us working together to achieve the outcomes that we're after. And so that means being there in the communities of Northern Ontario, where we're just about to launch a new strategic plan, and between May and September last year, Dr. David Marsh, who is the Associate Dean Community Engagement and Deputy Dean at NOSM, David Marsh and I visited something like 50 communities, and we, in each community, we had a couple of different sessions with people generally from the community and also with faculty members and people in the hospital and so on. and we were seeking input from them. Some of these pictures are from Chapleau Cree First Nation. That's when we had our Aboriginal Community Partnership gathering, and so that was in August. So during the time we were in the engagement phase of developing our strategic plan. And so we have our 2020 vision, which has been developed with a huge amount of input, over 1,000 individual inputs in bringing together, so that we've really made an effort to ensure that this plan reflects what the people in Northern Ontario see as the important priorities for the next stage, the next phase of development of Northern Ontario School of Medicine. So let me share with you just some of the outcomes of what we've been doing in Northern Ontario over the last 10 years, starting with the results of our selection and admissions process. So with our social accountability mandate and the research evidence I mentioned before, we set ourselves the target of reflecting the population distribution of Northern Ontario in each class, okay? And you can see we've been fairly successful. 92% of our students have grown up in Northern Ontario. The other 8% come from remote and rural parts of the rest of Canada. It's actually rare to have a student in our class who comes from a city from outside of Northern Ontario. And if you take out the 5 larger population centres I mentioned, about 40% of the population of Northern Ontario are rural remote. So we're right on those demographics. Similar for Francophone, 22%. Not quite there for Aboriginal. So 7% of our students are Aboriginal. We're aiming for 10, 12%, which would reflect the demographics in Northern Ontario. But you can see the issue. We have, this works out at about over 2,000 applications each year for 64 places in our class. And we get about 40 Aboriginal applicants out of 2,000. So that's 2% of the application pool, okay? The Aboriginal people themselves recommended that there's no special treatment in the sense of lowering the standards, so that the Aboriginal applicants have to meet the same standards and compete for their place in school just like all the other applicants. We do have an Aboriginal admissions subcommittee and a stream, so there are special evening sessions for potential Aboriginal applicants to help them to write the best looking application form they can, but they have to do that themselves. And then the subcommittee looks at the Aboriginal applicants and selects those who are called for interview. We use the multiple mini-interview. And then only for the Aboriginal applicants called for interview do we provide a training session to help them to present themselves the best they can in the interviews. And so you can see that's making a difference. 2% of the application pool, 7% of the class. That is having the desired effect. But what we need is to expand the application pool. And so we have, right at the beginning of that life cycle, even in the elementary school, encouraging the young people in the First Nation, the Aboriginal community, to see a future for themselves that might include a health career and particularly studying medicine. So when our students are in those Aboriginal communities in first year, they actually go into the elementary schools and the high schools and they talk to the students there about themselves and encourage that interest. We have a health sciences summer camp every year at both universities, a week long, where particularly Aboriginal Francophone students from the small communities come in and they spend a week with our students and our faculty members doing a whole range of activities to make the connection between what they study in high school and health careers. So, of course, with the help of television, there's a bit of a CSI theme, so they have a bit of fun as well, of course. So that's what we're doing in terms of our selection admissions process. I did want to point out that at the point of admission, the mean grade point average is 3.7 out of 4. So it may not happen in Alberta, but certainly in Ontario, there's a bit of a sense in Toronto that we must have lowered the academic standards to let in all of these dumb northerners. And in fact, it's not true. 3.7 is pretty similar to the mean grade point average on entry for the other medical schools in Canada. So even though we have this selection admissions process that favours applicants from Northern Ontario, we have highly academically able medical students who are in our classes. So let's talk about our students and let's share some of the students' experience of our distributed community engaged learning. And you can see generalism is one of our 7 key academic principles. So the Academic Council has identified 7 key academic principles which provides the framework for the development, delivery and evaluation of our academic programs. And I must say I really like this one. You don't know it until you live it. I mean, I think that really sums up the learning in context, the philosophy, the importance of our students learning in the communities where we're encouraging and hoping that they will actually ultimately choose to provide health care. And in fact, that's what is happening. So just Tuesday this week, Friday last week was our 7th graduation from our MD program, and 62% of our graduates have chosen family medicine, mostly rural family medicine as their career direction. So for those of you from outside Canada, that's almost double the national average going into family medicine. The 33% into other general specialties like general internal medicine, general surgery, and 5% into subspecialties like dermatology, plastic surgery, radiation oncology, neurology. That 5% is really important to us for two reasons. One is we need those kind of subspecialists in Northern Ontario. They may have to go elsewhere for residency, but we expect and we're starting to see that they're coming back. The other is that it shows that even in studying medicine in Northern Ontario, even with our unusual curriculum model, that our students are not precluded from being competitive in the residency match to match into those competitive subspecialties. And in fact, I just happened to be in Iqaluit last week and met a neurologist from University of Ottawa who was very excited because their number one pick for the neurology residency program, our student was actually matched to their program. So we take that as a sign that the residency program directors across Canada want to have our students, our graduates, in their residency program. Most years, all of our students are matched in the first round of CARMS. If it's not every student, it's just one not matched. And that hasn't happened for other medical schools in Canada for over 15 years, like the whole class being matched in the first round of the residency match. So, I think that's an indication that our graduates stack up pretty well, albeit that they're choosing proportionally more of them choosing to train for rural practice. And now we can look at our residency programs. So 69% of our graduate residency programs at this stage, mostly family medicine, but increasingly some Royal College specialties, 69% practicing in Northern Ontario, 22% in the small communities. And then if you put together MD, Northern Ontario School of Medicine, residency in Northern Ontario, 94% of our graduates are practicing in Northern Ontario, 33% in the small communities. I guess the sort of most spectacular headline story is a place called Chapleau. I mentioned Chapleau Cree First Nation. We were there in August. Chapleau is a community of about 3,000 people. It is 2 hours from anywhere. And they went for nearly 7 years without a permanent doctor. Since July 2012, they've had 3 homegrown physicians. Homegrown as defined by the 3 physicians that grew up in Chapleau. They did their MD and their family medicine residency with us, and now they're practicing together in Chapleau. And one of them, Doris Mitchells, is First Nation, and she's actually serving her own people. Brunswick House First Nation is one of the 2 First Nations in the sort of Chapleau area. So that's the most spectacular story. We have others that maybe not quite as spectacular, but that's the kind of direction that we're finding in terms of graduates. I'm focusing on medicine, but it's similar for the other programs as well. So what about the socioeconomic impact of the school? We did a study in 2007-8-9 looking, first of all, the economic impact in the 2007-8 fiscal year. And in that year, the budget for the school was $37 million. The level of new economic activity was something between $67 and $82 million. So that's more or less a 2-for-1 multiplier effect. There was economic growth, that's new jobs. Economic development, that's new job categories that we wouldn't have in Northern Ontario without a medical school. So that was very exciting to see, and I think important, and very important. It's about return on investment because, of course, the per student per year, per resident per year cost of our model, distributed learning, is higher than the standard model in the big city teaching hospital. So to demonstrate the wider economic benefit was important. And in fact, we've just in January this year published a further analysis which shows that this economic benefit flows through even to the small communities. It's more or less proportional to the number of learners that we have in each community. As part of that study, we also looked at the social impact. That was in 2009. Researchers interviewed individuals and groups, key opinion leaders. And 2009 was just after the global financial crisis, you might remember. Things looked pretty bad for the whole world, and certainly in the resource-based economy of Northern Ontario. So you would expect the people in the communities to have been pessimistic about the future. That's not what the researchers found. What they found was that people were optimistic about the future, and they connected their optimism to Northern Ontario School of Medicine. And it wasn't just about more doctors and access to healthcare. It was actually, there was a sense of empowerment. You know, they'd been part of that community movement to get the medical school. Now it's there, it's a success. There was a sense that if we can do a successful medical school, we can do anything. And in fact, Lakehead University now has a law school. Laurentian University now has an architecture school. And I think it's fair to say that neither university would have got past first base with proposing those sort of professional schools without the success of NOSM for them to point to. Okay, so putting this together about NOSM, the benefits are much more than just more doctors and other health professionals. The kind of health professionals who are team players, who are sensitive, responsive to the social, cultural, linguistic, geographic diversity of Northern Ontario. And it's also about the research and the academic and the economic developments. So we've talked about Northern Ontario, now let's get back to the whole world and talk about the Training for Health Equity Network. It's a global movement of schools committed to transforming health professions education to improve health equity. So it's a group of schools. The initial group was 8 schools that came together in December of 2008. All the schools have a social accountability mandate, and we have been working at developing a community of practice around the world. So the Zamboanga School of Medicine and Chris is one of the members, and Patan Academy of Health Sciences another member. So we have literally around the world members of the Training for Health Equity Network. And although, you know, the Mindanao Island in the Philippines is very different from Northern Ontario, is very different from we have 2 schools in Australia. I'm going to say a bit more about Walter Sisulu University in South Africa. Very different context, but we found there were 9 key elements that were actually common to all of these schools. And the first one is very much about being guided by the community, the education happening in or very close to the community, so that sort of constellation of issues around community, a curriculum that does integrate the population health and the individual focus with early clinical exposure, education that's learner-centered, making sensible use of electronic communications, and very much partnering with local health services, supporting the local healthcare providers as the clinical teachers, and with an emphasis on service. The students are learning in service settings to be service providers in those clinical settings. So these are these 9 common principles that are there across all of the. There are now 12 or 11 or 12 schools who are part of the Training for Health Equity Network. And our first task we set for ourselves was to develop an evaluation framework to actually measure how well we were doing. We drew on the work of I mentioned Charles Boland and Bob Willard in terms of the conceptual framework that they had developed, and so we tested that out, and that was really the beginning of a quite an extensive research agenda. It's about putting together the evidence to demonstrate that social accountability makes a difference, that it works or doesn't work, and what about social accountability, so that we can share that experience amongst ourselves and then with others, and that's where the community of practice idea is taking form. There's already been some work and a publication looking at the selection admissions process of the schools. I told you in depth about Northern Ontario School of Medicine. The common theme is recruiting students from the underserved community settings and having their education in that setting. And we're exploring learners' perception. What does social accountability mean to the learners? Okay, looking at what happens to the graduates after they graduate. I shared some of the tracking study data from Northern Ontario. Similar studies are now across schools in the THEnet, the Training for Health Equity Network. Return on investment, similar concept to what I've described in Northern Ontario. We have some special funding. There are actually 2 schools, members of the THEnet in the Philippines. You know about Zamboanga. The other is at it's the School of Health Sciences in Leyte. It's part of the University of Manila. And interestingly, you have a situation where Zamboanga is part of the Ateneo University Network, which is so it's considered private because they're Jesuit universities. So there's actually an Ateneo medical school in Manila now. And there's also University of Philippines has their main traditional medical college in Manila. So it's a study comparing the two schools under both universities, and I think it's going to be very interesting to see the impact of, this is an impact study looking at those two. The Institute of Medicine in the US have initiated a forum on community engagement, which is being led by THEnet. And we're looking at the quality of graduates, so the skill set of the graduates from, in the first year after graduation, the graduates from THEnet schools. So that gives you a sense of what we're doing as a collective around the world with the Training for Health Equity Network. I said I'd say a little bit about Walter Sisulu. I figured you know about Zamboanga and you know about Patan. So let's talk about Walter Sisulu University. So this is South Africa as a whole, and this is the Eastern Cape and KwaZulu-Natal. So Umtata was the capital of Transkei. That was one of the black homelands in the apartheid era. And it must have been a real act of defiance to establish a medical school by the University of Transkei in Umtata and specifically to recruit local students into this new medical school. This was back in 1985. Actually, 25 years later, they were celebrating 25 years since their official opening in 2010, and the actual conference that brought together the global consensus on socially accountable education occurred here at East London, hosted by Walter Sisulu University School of Medicine. So Walter Sisulu is another member of the Training for Health Equity Network, and similar to the others that you've heard about before, the focus on recruiting, not looking at just at academic scores, but likely success, recruiting local students, training them locally, and the desired effect. 80% of their graduates are practicing in the rural, deprived areas of Eastern Cape and KwaZulu-Natal province in South Africa, remembering that such a high proportion of South African graduates seem to find their way out of South Africa to practice in other parts of the world, such as Canada. So this is, again, I think, an impressive indication of the value of the social accountable education approach in terms of delivering what communities need. So let's just sort of bring this together a bit. I introduced the concepts of social accountability and global health, or global health social accountability, with the emphasis on achieving health equity. Told you about Northern Ontario School of Medicine with the feature of distributed community-engaged learning, and I've introduced the Training for Health Equity Network, THEnet, and highlighted Walter Sisulu University. So I would say what's really essential for success, bringing together social accountability, global health, is recognizing context is critical. It's all about context in a way, and the context is the communities, and it's active community participation, working with the communities, responding to community needs, always with a focus on the highest standards and quality. And so that means the kind of work that I've described of documenting what you do, testing it out, demonstrating, producing the evidence. And with all of that, there still are many, 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 many naysayers, critics, who of course poo-poo all of this. I mean, everyone knows that you can only produce good doctors in big city teaching hospitals. So what I recommend is you listen politely and you smile and nod and just kind of, keep it cool. But keep your eyes on the prize. I mean, it is about the vision, the mission, the values. That's the secret to success, the essentials for success. So in conclusion, I would suggest that we actually need an alternative to the current international standard. Like even in the most disadvantaged, low-income country, no one wants to be seen to have a second-class medical school. So the current international standard is the graduates have the skills and the potential to be interns in the teaching hospitals of New York, London, Paris, right? So that's what they do. And so a medical degree is a passport out of the country, which adds to the disadvantage of that country. Surely we need an alternative international standard, something that is guided by the focus of social accountability and global health on achieving health equity. So it's about recruiting students from the underserved community settings, providing them with education in those settings. So then you produce graduates who have the commitment and have the skills and the commitment to provide care where it's most needed, always responding to community needs. I've got references, and also down the front there are one page, I think it's printed out as 2 pages, about Northern Ontario School of Medicine, and there are sheets. We had a bit of toing and froing, but rather than having other handouts, if you'd like these references, if you'd like other information about Northern Ontario School of Medicine, if you put your name on the sheet there with your email address, we'll send you the links, we'll send you the documents, and including a PDF of the slides that I've presented today. So that's it. I'd be very happy to respond to any questions or comments. Yes, Gang.
Remarkable work, congratulations. I was telling Dr. Strauss, I grew up in Timmins, Ontario, which is even more north than Sudbury, 180 kilometers north of Alberta. But this is absolutely incredible what you do. I have 2 questions for you. The first is, have you assessed your stakeholders' perceptions in terms of the people living in the community? Have you done any qualitative research around how people feel to have physicians?
Hello?
Yes.
How people feel to have the program there. I noticed that you talk to your learners and you've done some economic assessments, but I wonder what the people that live in those communities feel. And then my second question is, with a move towards competency-based training in all medical schools, so the Royal College of Physicians and Surgeons of Canada is restructuring its objectives of training to be competency-based, and then also entrustable professional activities that reflect the place where people will work. Do you think that that's going to further support your final slide where we should have standards of training that reflect training people for where they ultimately will practice?
Yeah, the short answer is yes. Let me, first of all, mention Timmins. You mentioned Timmins, and it was said I'm going to take the red eye tonight. That's the reason is I'm going to Timmins tomorrow, and I'll be in Timmins
Say hi
tomorrow.
to my mom.
Okay, well, okay. The reason I'll be in Timmins is tomorrow and Saturday is our 10th Northern Health Research Conference, and so the Associate Dean Research wanted me and her predecessor to be the after-dinner speaker tomorrow, reminiscing 10 years of Northern Health Research Conferences. And we rotate around Northern Ontario. It happens to be in Timmins tomorrow. So your question about are we looking at the impact on the communities beyond what I mentioned, the short answer is yes. There was more in the social impact study that I've already reported. And we're now just starting the next phase of research in terms of our tracking and impact studies, and asking people the sort of questions that you've raised. There's one other study that's about to be published, which I can report, which is about recruitment. So we interviewed, I think it was 10 communities, people involved in recruitment of physicians in those communities, and these are all communities that now have physicians who were NOSM graduates, right? And what we found was that already there's been a change in their mindset. So it's moved from crisis management, we've got to always be looking for more doctors to fill gaps and that sort of thing, to planned recruitment, okay? Haven't got to the point of a focus on retention and a sort of longer term planning, but at least moving in that direction. And comments unsolicited about how they're already spending less money on recruitment than years. So that's another dimension, if you like, of the economic impact. So we are actually gearing up to look at a whole lot of different aspects of the impact of the school on the communities. Of course, the holy grail is to be able to demonstrate improvement in the health of the people. That's probably going to take a bit longer for us to be able to get to that point, but we're certainly looking at those sort of other aspects. And then competency-based education. It was actually way back when I was with Monash and starting Monash Rural Health, that we had a bit of a breakthrough because the Department of Obstetrics Gynecology there at Monash, which is in the big city of Melbourne, decided to move to competency-based education for their students doing obstetrics gynecology And they were really serious about that. So they identified the specific knowledge, skills, attitudes that students need to have to graduate in medicine, to be ready to graduate in medicine in terms of obstetrics gynecology. And so, you know, it was about the practical things like vaginal bleeding, and not necessarily having to know about hot and cold running gynecological cancers, and being able to do procedures. And they followed through on that, so that, those students who spend all their time in the books and know every last little piece of minutiae, those students failed the exams because they couldn't do the practical things because they hadn't been in the OR, and those students, of course, were hopping that. So that's what competency-based education means, right? And that, of course, opened up a realization that medical students could learn those skills not just in the city teaching hospital, but actually in metropolitan hospitals and rural hospitals and so on. And so that was a big step forward for us. And I would say that it's still the same. When you come to competency-based education, you take out this assumption that you can only learn this and that in whatever specialty in a particular sort of hothouse environment of a teaching hospital. So we already are embracing competency-based education with our family medicine residency program. We have a new anesthesiology program just started last year, and it's all competency-based. So we're looking to be sort of ahead of the curve as far as that's concerned.
As a former family doctor in a small rural community in northern Ontario, I was tremendously impressed with what you have accomplished in 10 years. I think it's truly remarkable, and I congratulate you.
Thank you.
I'm interested a little bit in the funding side of things, and I wonder if you could tell us how your tuition fees compare with other schools in the more southern parts of the country, and what mechanisms are available to provide financial support for the students, because I'm quite certain that a lot of the successful applicants from these small communities in northern Ontario are not well immersed with financial backing.
Absolutely right. So with that selection admission process and 92% of students growing up in Northern Ontario, our students have a lower average family income than medical students in other schools. Our board of directors has made a commitment, really, that our students shouldn't be financially disadvantaged through studying medicine with Northern Ontario School of Medicine. So we've set our tuition fees to be around the middle, actually a bit lower than the middle of the range in Ontario. And we, right in the first year, the 2005-06 year, we had a big bursary fund campaign. We raised almost $13 million in less than a year. It's now over $21 million. So we have an endowment to provide student financial aid. So there's a big emphasis on supporting our students financially. Just to say a bit more about the financial situation more generally of the school, I mentioned that the model that we have, the per student per year and per resident per year dollar figure is greater than for the sort of standard model. We've got lots of students in a small, in a sort of concentrated setting. And that was the design of the school from the beginning. And so it's been very important for us to demonstrate that bigger picture return on investment, that actually spending this money now saves money in the long run and reduce costs of locums and recruitments and new economic activity that wasn't there before. To counter, as things are tight in Ontario financially at the moment, counter the view, well, you know, we can't afford the luxury of the boutique school in the north anymore. We'll just close that one down and have all the students in Toronto. So there are lots of different dimensions to the financial side of things. But in terms of supporting the students, the vast majority of our students are receiving student financial aid because of our bursary fund.
Thank you. You've changed the paradigm of medical schools in Canada, and you're a bit unique. And one of your missions, as you alluded to, is still research. So have the public funding agencies responded to your presence by changing the rules of engagement for applying to grants? And how do you compete against the traditional schools?
I'll say not yet. Yeah, I mean, certainly we have some of our researchers are competitive and receive grants from CIHR and CERC in particular. But of CHIRC, but it's early days yet. Our faculty members in starting the school and until fairly recently were much preoccupied in developing and delivering the curriculum, and so in the last couple of years, research has become a major push for the school, and certainly it's a major priority in the new strategic plan. It is fair to say that much of the research is not, at this stage, is not funded through those sort of traditional avenues of the competitive tri-council grants, but we've done quite well from some of the other non-government granting bodies. I think, say for example, Heart and Stroke Foundation. There's probably a degree of guilt really because Northerners are so prolific givers and they went, there wasn't that much of the money coming back to the North, so that helped them to provide funding, heart and stroke funding for our medical students to do summer research projects. We have a Heart and Stroke Foundation research chair in Northern and Rural Health. So we are getting support in one way or another from those sort of sources. And we've certainly had assistance in getting research infrastructure up from the economic development agencies in Northern Ontario. So there's a federal one called FedNor and a provincial one called the Northern Ontario Heritage Fund Corporation, and they've certainly helped with infrastructure. And also they have internship programs. So in the early years, it's meant to be interns to work in manufacturing industry and mining and stuff, but we said, well, let's have research interns. And so, and that was fantastic because we have quite a number of faculty members who are busy clinicians who do research but don't have time to write it up, and so that improved the productivity of quite a few of our researchers. So we've had to sort of take some novel approaches, shall we say, to get our research effort going. But it is going and is building, and there's, I think, a genuine momentum now. And we're working on those agencies about adapting their criteria as well.
I'm not part of the Fitbit challenge. Thank you, Dr. Strasser. That was a very interesting and inspiring lecture. My name's Bonnie Larson. I'm an inner-city family doc here in Calgary. My question is, NOSM has been so innovative in so many ways and inspiring to those of us who work with these populations, both rurally and in an urban setting. I'm curious to know, I noticed for the South African example that they are recruiting for potential success. And I'm curious to know where NOSM sits in terms of changing the recruitment process for Aboriginal students, or what beyond going into the elementary schools are you guys thinking in terms of being innovative that way and getting more Aboriginal students into medical school?
Yeah, it's a good question. So I gave you a bit of the story with NOSM. A key element of how we come to have almost all our students from Northern Ontario or other remote rural is a part of our process called the context score, which gives maximum score if they come from Northern Ontario or the Aboriginal, Francophone, rural, remote background. And so we're now looking at tweaking that further and maybe taking into account other factors that suggest that an applicant who comes from a remote First Nation in Northern Ontario who really hasn't had the opportunity to maybe get the sort of education opportunities and towards the academic, but in other ways shows signs of having the potential to build that into the scoring in some ways so that they have a chance. Still maintain, staying true to the recommendation, as I said, from the Aboriginal people about that they have to earn their place in medical school. I mean, it is an advantage to us really because our Aboriginal students do just as well, just as badly as the other students. We don't, where there have been examples of quotas and students, Aboriginal students coming in without necessarily the academic strength, they've struggled. And so it's, we did it because that's what we were advised to do by the Aboriginal people themselves, but it's proved to be good advice, I suppose. We're also looking at sort of strengthening the pathway, bridging type programs. The universities, Lakehead has one for nursing, Laurentian has one for what they call Native Human Services social work for Aboriginal people, and we're looking at that kind of pathway as well. yeah, that's a good. Are we thinking something earlier than that? I mean, the answer is yes, but we're a medical school. Okay, I mean, we're working with communities and education agencies at the sort of K to 12 because that's their territory. It's we can support and work with them and encourage that, but it's not at least at the moment we don't have the resources to be able to do that ourselves.
All right, I'd like to thank you both for an outstanding presentation and for the great work of you and all the people behind you. It's just amazing what you've presented today, so thank you very much. I hope you have a safe journey back to Timmins and you enjoy the red eye and have a beer on me on the plane. Gwen, do you want to talk about the program tomorrow and the schedule?
Following the lecture this afternoon, you're welcome to join the reception. It's just downstairs by the Hippocrates statue. And then for the Bethune Roundtable, for those of you who will be attending that, we will be starting at 7:30 tomorrow morning, and it will include general surgery department rounds along with anesthesia. And if you are by the statue sometime between 7 o'clock and 7:30, we will usher you to where the lecture will be because it's actually in the Foothills Hospital. So I think that would. So if for those that don't know how to get there, if you're by the Hippocrates statue, we will usher you to where you need to be. So again, Dr. Strasser, I thank you for a very stimulating lecture, and I hope you will join us for the reception. Thank you.